please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
I can't remember which rule it is, but it's the rule that says what you need shows up. It just doesn't always look like what you thought it was going to look like.
Oh man, I love that.
Because when I was in the busy practice in Gresham, Jenny would say on Wednesday or Tuesday, she'd say, "Did you decide you needed rest?" It's like, "Why do you ask?" And she said, "Because your entire Friday afternoon," and that would be 8 patients, all just canceled or rescheduled.
It's amazing how that happens.
It's just like that.
I heard another quote. I think I was telling you, I'm taking this mindset coaching course right now, which has been just wonderful. You get to write an essay and you get to post your essay and people talk about what you wrote. And it's very different than anything I've ever done.
Where did I get that from you?
Peter Twist is doing it online.
Oh, okay.
It's fantastic. But one of the phrases that popped up was, he's got these very inspirational quotes that he comes up with. And one thing jumped out at me last week, and it was, "You are right on time." And I'm like, I am right on time, because there's so many times where we project and we want to be in the future and we want to just get to the destination and we just want to learn everything as fast as we can and treat all the patients and do all the things. And there is a process bigger than what we know. And we always talk about this too. When we have a week where we're seeing all of the same sort of ailments and problems, it's okay. What am I supposed to learn here? I'm supposed to learn something about the shoulder today. I'm supposed to learn something about the ankle. I'm supposed to learn something more about the viscera, because all I'm seeing are these cases.
Oh, speaking of which,
That a very organic transition to talking about some things.
this last weekend, Saturday, Sunday, was a 2-day practicum for people that took the course. One guy took it in 2008, but almost everybody in the class took it in 2023, took it last year on video, and this was their practicum. And one of the people in the class is a nurse, and she had these, she said, "I have these lumps in my abdomen and they're really painful." And you know how the practicum goes, that's probably scarring in the nerve and inflammation in the nerve, run that. And then I went on to another table and did my thing. She came as a patient on Tuesday. And it's, oh, now I have a chance to figure out what painful subcutaneous fat lumps are. And I had more history, which of course we don't get during a practicum. And I have this timeline, and I'm feeling these little, they feel like Tootsie Rolls in the subcutaneous fat. So everybody has subcutaneous fat everywhere, but these were in her abdomen, especially on the sides, but even down towards her pubic bone, and exquisitely painful. And I did inflammation, the fat, it did nothing. I did the things I thought of, didn't do anything. And then I asked her, when did these start? I had COVID, and then this, and then that, and then these things started. Okay, so it was after COVID. But I've never seen ever in 30 years of practice, or however many years it's been, 27, painful lumps in subcutaneous fat. I Googled.
Are they always painful, or just upon palpation or with pressure?
Oh, it's painful to touch.
Okay.
So when she fastens her jeans, when she touches her abdomen, when she sits down, because the ones, your little saddlebags there.
Yeah.
So I Googled subcutaneous fat pain. She's been to 6, 7 MDs asking for a diagnosis. Oh, it's normal. No, it's not. There's lumps. They hurt. Oh. So it was after COVID, and she had Cushing's, so really elevated steroids at some point for a pituitary thing, and subcutaneous fat pain. And there's the diagnosis, panniculitis. I'd never heard of it.
Panniculitis.
Panniculitis. Then you read it, and it's like painful lumps in the subcutaneous fat that feel like small rolls, and following, and then it lists the causes. Viral infections, bacterial infections, no. Steroids. It was all right there.
Wow.
And the solution, I don't have a frequency for steroids, but I have a frequency for COVID. So I ran all the viruses in the adipose.
Yeah.
The whole left side just disappeared, like all the little Tootsie Rolls are gone. And then her QLs and her psoas were really painful on the left. And she said, oh yeah, I had a kidney infection. So we did scarring in the ureter, scarring in the kidneys, sclerosis in the fat pad. And that completely took care of the left side. But by then the hour and a half that I had to treat was gone. And I'll see her again tomorrow or Friday, and we'll get rid of the right side. But it was a matter of nobody else just looked it up.
Do you think, and I don't know, I could be talking just out of my elbow here, but sometimes the whole, oh, it's nothing, or it's normal. Of course, the dog barks right when I need to speak. When doctors or physicians or whoever is giving that diagnosis, I even saw this with surgeons, it's because they can't treat it.
I agree with him, the dog. It may be because they can't treat it, but for patients, having the name and knowing that it was a thing, that gives them mental soothing.
Yes.
That's just, oh, okay, it's a real thing. I'm not just.
Well, yeah. And the whole it's nothing or it's normal or whatever is so dismissive, and it's mean.
Lazy. Really, I got my phone out and I could palpate. No, she's right. There's little Tootsie Rolls, but it's not deep in the abdomen. So it's not liposarcoma. It's not that.
Yeah.
It's in the subcutaneous fat.
And even just to say, this is what I think it is. There's no real way I know how to treat it, but it looks as though your symptoms fit this. Even changing something like that is just, it's validating is the word I'm looking for.
Yeah. And in our world, you can look up. So I'm sitting there showing her on whatever WebMD. This is what it is. These are the causes. And she said, oh, I had elevated steroids when I had Cushing's. Yeah. And then there's that virus thing. And just validating is a good word. Linda Avery, do I have a frequency for treating lipomas? Yes, but it doesn't work. Lipoma in the breast. One patient has this diagnosis. This is true confessions time. I had a lipoma in probably my left breast, and it just popped up one day. They're very superficial. It was soft, mobile. I knew it wasn't cancerous because it was soft and mobile. It was clearly lipoma. I was not about to go to an OBGYN because then we would go down the cancer rabbit hole. It's a lipoma. So I made an appointment with a dermatologist, and he looked at it and said, made suspicious, concerned face. And I looked at him and I said, it's a lipoma. I promise you that if you take it out, you biopsy it, because I know you will, and you tell me what it is. If it's anything except a lipoma, I promise I will go down the rabbit hole. And he went, rolled his eyes, little local anesthetic. You take like literally a 2 millimeter, this was very small, 2 millimeter incision, and they just pop out. And then one little stitch, or not even that, just one of those little Band-Aid things. And 3 weeks later, I get an email that says, it's a lipoma. Ta-da. Linda, the time I have treated lipomas, the one I treated was the size of a softball. And this guy had multiple ones, but this one was by his shoulder blade. And I treated it with the frequencies we have for lipomas. And the thing shrunk by about 50%, but I couldn't get rid of it. It was too big. And I never treated myself because lipomas are very superficial. They're not encapsulated. If you catch them before they get innervated or scarred down, have her go see a dermatologist. It's outside our wheelhouse. It's just, there's a place for everything. That's not a place where I would go. Hi, Leaf.
Speaking of place for everything, you're going to like some of these topics today because it's very neurocentric. So I have a bit of a beef. I have a complaint.
Oh, good.
So when I hear somebody comes in with irreversible / permanent nerve damage that is numbness, insert eye roll, shake head.
Just love that part.
Yeah. So again, what does this come from? Does this come from surgeons that are just saying that because they don't want it to make it seem like they made an error, or that they just don't know how to fix it? Because when I can create change in 20 minutes, it's not permanent or irreversible.
No, it's just that the surgeon doesn't have a way to fix it. He didn't cause it. The disc herniation that he operated on, the disc caused it. The disc nucleus has the ability to demyelinate a nerve in 28 days. So the patient has a disc bulge with a fragment, and he lives with the pain, waits for 6 or 8 weeks for the insurance to approve the surgery. He lives with physical therapy for 6 or 8 weeks. They use the TENS, blah, blah, blah. And then the surgeon does the surgery, pulls the fragment off the nerve, fixes the disc, puts in the insert, sews it up, happily ever after. And the patient has numbness and foot drop. Numbness and foot drop, not my fault. It was the disc. I can't fix it. And then if he's lucky, he walks into your office and it's, oh, goody, something I can fix. It's like you do 40 and 396 for, we had somebody on the weekend with a numb thumb and a numb index finger and a little bit of fuzziness here. So 6 and 7, but really 6 was just numb, like dull. I said, so just treat it. During the practicum, they wrapped a towel around her neck. This was Sunday afternoon in the free-for-all. And they wrapped a towel around her hand and they did 40 and 396. And then 81. So reduce inflammation in the nerve first and then increase secretions in the nerve. In about 15 minutes, her fingers were hyperesthetic. Why is that good news?
That's what happens.
When a nerve goes from numb back to normal, it goes through numb, hyperesthesia, normal, just like when it went from normal through hyperesthesia to numb, it's got to go back the other way. So give it another 10 or 15 minutes, she'll be done. The sensation was all normal. That was really fun.
And I remember my first in-person core when you said nerve pain is going to be one of the easiest things that you treat. And I was like, did everybody just hear that? Nerve pain is going to be the easiest thing that we treat. Say that one more time for the people in the back, because
nobody, and there's no reason you should believe me until you do it.
Until you do it. That's right. So I want to talk a little bit about numbness here. When we talk about 40 and 396, until that doesn't work and you actually need 81 and 396.
You almost always, for motor and sensory, you need both.
You need both.
And that's the way it is. And then somebody said, what's time dependent? And it's like when you're treating a nerve and restoring, like foot drop and atrophy, muscle atrophy, right? You treat it and it takes 30 to 60 minutes to get rid of foot drop. It's not that hard, usually. And they said, why does it take so long? And it's, we did the weekend at our conference center, our Troutdale campus.
Yes.
And on the wall, Kevin has the graphics that we had printed for the clinic. And there's be realistic, expect a miracle, but be patient. The impossible takes slightly longer than the difficult. And they said, you understand that 7-year chronic foot drop is impossible. Foot drop, period, is impossible. So the fact that it takes 60 minutes, well, why does it take 60 minutes? And why do you have to set it up from the low back to the foot? And I said, my answer to that is when you're treating a nerve, you have the effect of the frequencies. This is why I want a squid axon and a PhD in neuroscience, because you've got the frequency, you have to do 40 and 396 and then 81 and 396 to get rid of foot drop. But you also have to have the current because nerves have voltage gated ion channels that kind of get stuck open when they need to be closed or vice versa. And you drive current and voltage down these little voltage gated ion channels and flip them back where they belong and give them 5 times the ATP. And there you go. But you have to treat it for the right thing. Foot drop from a low back disc is just treating the nerve. But remember 2003 or 4, there was this MD in the class who had foot drop. And I assumed it was from the low back. So we ran 40 and 396, 81 and 396. And I come back to the table 30 minutes later and he's still got foot drop. And that's not normal. How did you get foot drop? Now he was, I think, 54 or so at the time. And he said, from the age of 5 to the age of 7, I was in the hospital for polio. And I've had foot drop ever since. Oh, okay. We have a frequency for polio. So I put 23, poliomyelitis, on channel A and 396 on channel B for the nerve that went from his low back to his foot. But I also put around his neck down to his foot because polio attacks the nerve and the cord. Ran polio in the cord. And in 45 minutes, full function, and it was permanent because he showed up in an exhibit 10 years later. And I'm talking to people that are at the booth and he comes by and he's 6'5". And he said, believe what she says, because see that foot? It didn't move for 50 years. And then in 1 hour, this stuff fixed it.
Wow.
Yeah, it was so fun.
So, like always, there's just so much to unpack when you tell a story. But one of the things, just to talk about something you just ended on, was like permanent change that we create. And people are, how is that possible? How does it just permanently fix something? So everything is just someone wrote to me, so you should just treat somebody one time and then it's done. I said, no, that's not
realistic.
It's not realistic because other things are going to change. And this is why charting is so important, because you're charting pain before, range of motion before, then you have your treatment, then the pain, then the range of motion. And then the second time they come in, I want that end range of motion to match the beginning range of motion of treatment 2, if that makes sense. So how they're leaving after treatment 1, I want them walking back in the same way. I don't want them to backslide. I don't want them to lose range of motion. Otherwise, and we talk about this all the time, otherwise it's just a party trick that you do in the clinic.
We had the same questions during this practicum weekend. And I said, okay, so you treat the disc, you treat the nerve, and that's why we talk about twice a week for 4 to 6 weeks. So having a disc bulge, let's say in your neck, and having nerve pain down in your finger and thumb, it's like having a sprained ankle in your neck. You have a jelly donut in your neck, you tip your head forward, the donut goes this way, the jelly goes that way, and you've got little cracks in the donut. In order to fix the donut, you have to not break it.
Yeah.
Again. So the patient leaves, their nerve pain's gone, the pain in between their shoulder blades is gone. And then you tell the patient, this is how you sit. You are not allowed to do this for 6 weeks. You can't look down because then you do the jelly donut thing. And you also can't put your arm out and lift anything with your straight arm.
Yeah.
Because if you have a 1 pound, let's say a 5 pound weight, and you've got your hand here, it weighs 5 pounds. You put it on the end of a 3 or 4 foot lever arm, and it weighs 15 to 20 pounds. And that pulls down on your neck, which squishes the jelly donut. So there's what you talk about with muscle balance. Are you going to retrain those in a 60-minute session? No, you have to create a stable state. So we talked about it. It's like, how do you tell a patient how to sit? What's that got to do with it? If they're sitting like this, they're going to come back with the treatment's going to last about 3 hours. If you teach them how to sit and they follow your directions, pretty good chance the treatment's going to last the 2 days that it takes for you to see them next time. And you teach them little teeny exercises, blah, blah, blah. So we have to, it is a party trick,
Yeah.
but it gets the patient's attention.
Yeah.
And then they will listen to you.
Yeah.
And then they will understand it when they look down and the pain comes back.
Right.
Yeah, she told me that was going to happen.
Yeah. And I think, again, for me, it all comes down to the word safety. Like, what is the safe move here? So whether it is our favorite midbrain, convincing that undoing all this scar tissue is safe, convincing it that this extra range of motion that we just created, now we can activate these muscles, that is safe. That is this joint safe? Is there ligature that's lax and the muscles are splinting because that created safety? So I'm always thinking, say, what's the safe play here? Because if you're leaving somebody or a part vulnerable, you're going to get into trouble.
Yes. And
Too fast, too soon.
too fast, too soon. And it means that FSM practitioners are not only therapists, they're teachers.
Yes.
It is important to explain to patients what's going on. And I have a disc. And yeah, but that's not what's making your back hurt. Your pain stops at your knees. What? This is lean back. Ow, yeah, that's my sciatica. No, that's your facets. And then you show them the facet pain diagram and where the pain comes from. And then what exercises to do, how to sleep, how to sit, how to strengthen their core. And it's twice a week for 4 to 6 weeks. And if you're done at 3 weeks, you're a hero. And if it takes 6 weeks, it's what you told them to expect.
Right.
So,
I think it's also, like, for me, important to talk about the whole maintenance program as well, especially for active people. I mean, for anybody really. And I'll explain it. It's just about where that maintenance schedule is going to be. If you're driving an older car, it's going in for maintenance a little bit more than something that's 1 year old. So whether that's an age thing or an activity thing, the athletes are tearing and breaking a lot faster than your average everyday person. So for some people, it's coming in once a month. For some people, it's every 6 weeks. For some people, it's every 2 weeks. For some people, it's once a week. And it's just figuring that out with the patient, with the condition, with their
And
life.
And that's after you fix
Right.
the original thing. And
Right.
then it's okay. You can come and see me. You can get a custom care. If the custom care stops working for whatever you need it to work on, then you come see me. And that's the maintenance schedule.
Yeah. I just was thinking about somebody that I was seeing for a frozen shoulder who came in with a pretty significant frozen, I would say maybe 45 degrees frozen shoulder.
Wow.
It's now 100% symmetrical, but has neck pain. And then when we have the conversation, it's this neck pain isn't new. This neck pain has been there 25 years. It was chronic neck pain in college. It was chronic neck pain as a young adult. And then you get busy and then you get frozen shoulder and then the frozen shoulder goes away and it's the neck pain was, I haven't seen one shoulder pathology that doesn't involve the neck. It cannot not involve the neck, obviously. But I thought that was funny. That made me think about you. So when it's patient education about, okay, yes, it's frustrating that you're still coming in to see me, but look at your shoulder. So sometimes it's that layer of the onion where you fix the original problem, but then you get a very slap in the face of what the driver of the pathology was in the first place.
Speaking of layers of the onion, this is a complete lane change because it's not physical. So at the practicum, I had probably one of the most profound experiences I've had in all the time I've been doing this. So it was the last practicum of the day. So everybody got to do whatever. They were doing the supine lumbar practicum. And the two people treating this patient on the table, there was an acupuncturist on this side and an MD, functional medicine, family practice doc on the other side. And the patient had low back pain and they dug in on her psoas and the back muscles were tight. And the acupuncturist picks up her wrists and checks her pulses. And I said, what do you have? How's the kidney and the spleen? Because he was on her left arm. And he said, kidney's okay, but spleen is slippery. And I said, what's slippery mean? And he said, out of balance. It's not tinny, it's not damp, it's just not right. Okay, we have this frequency 35 on A for balancing the energy centers, right? You could use 35 to balance a meridian because the meridians are basically flows of energy. So we did 35 and the spleen, we used 13. And 10 seconds, he said, oh, a pulse is normal. And thanks to Pat Lawless and Sandra Megan and my first core with them in 2003, we were treating Pat, and Megan was trained in China, and they were trying to balance the kidney and the spleen meridian. And they kept bouncing back and forth. And Megan said, the lung is the mother of the kidney. That's the only thing I know about Chinese medicine. The lung meridian is what feeds the kidney and the spleen. So I said, let's see what the lung does. So we treat balance in the lung, 17. And while that's running, I asked the patient, when did all this start? When did this back pain start? And she said, after my dad committed suicide. Oh, okay. Lung is a good thing. And then that ran for about 5 minutes before it settled down. And then the MD reaches under her back and says, the place where she hurts is right here. And you could see where she put her hand. If you know the acupuncture meridians, that's right on the bladder meridian. Bladder is hurt feelings. Her dad died 4 years ago, and she's done a lot of emotional work. So there's no overt emotion about it. Right. So you don't want to run 970 on the bladder, but bladder meridian, we ran balance in the bladder So I just had my hands on her tummy, and you could feel the chi start to move in the meridians.
Tell me what that felt like.
Have you ever been around a guitar and you take one of the high-pitched strings and you twang it?
Mhm.
There's this vibration. When the chi starts to flow, when there's no resistance in the meridian, it's like that vibration just settles down. It's smush, but more subtle.
Okay.
So I had the acupuncturist. I said, put your hands on her abdomen. So he put his hands really firm. And I said, no, just feel the chi. And he lightened up his touch and he said, oh. So then there's hurt feelings. And then also the back, or someplace in the back, is the small intestine meridian, which is abandonment. So 35 and the small intestine, and everything got smoother. And then the MD put her hand down on her, like her glute medius area, and said, right here is sore. And thanks to George, I have a picture in my head of the meridians. I looked at the acupuncturist. I said, that's gallbladder. He said, yeah, right there. So we ran 35 in the gallbladder, and the gallbladder emotion is resentment. She didn't have an emotion of resentment. So 970 and 38 actually made it worse, but 35 and the meridian smoothed it out, and she relaxed more, and you could feel this softening, just a millimeter off of her tummy. And then when you think about how the emotions are layered, you deal with the resentment first, then you get to the anger. And so we did 35 and the liver. And then she talked about how abusive her dad was before he and her mom got divorced. So there was resentment, but anger, and that ran the longest. And then she's crying at this point. She said, oh, that's such a relief. I feel so good. So you clear the meridians, and then we could go to 40 and 89. And then she got totally dwarfed and said, what just happened? 40 and 89. And so 40 and 89 is quieting the limbic system. The hippocampus gets paid to remember every bad or painful thing that ever happened to you. The amygdala is where the emotions are. So she'd worked through all that cognitively, emotionally. She's done a lot of personal growth work. And then we ran increased secretions in the vagus. And the MD looked at me and said, why? So you quiet down the hippocampus, and then the vagus tells the midbrain, the limbic system, that everything in the body is okay. And it was like watching 3 years worth of therapy in 30 minutes. And the MD said, you need to do a webinar about how all of these are layered. And I cover it in the last 30 minutes of the core, but everybody's brain dead by then.
Yeah.
And the challenge is that it's going to be different for everybody. I would not have run that order without the acupuncturist, without the history. So not everybody goes from grief to abandonment to hurt feelings. Not everybody does it in that order, but just the concept of, and that's what triggered this story, concept you had of layering. And if the emotions are like right up in your face, so if she was still angry about her dad, or she was still, but it's 4 years gone. And
But sometimes these emotions I don't want to say come from outer space, but I remember very clearly working with a man who had post-concussion syndrome from a motor vehicle accident. I'm going to say when I treated him, it was probably 5 years old. And he had brain fog, but super sweet and really motivated to get better. He was like the patient you dream about, that will do everything that you tell them with excitement and with hope. And after 4 treatments, got significant change. He came in for a 5th, mad, angry, like personality change. I'm like, whoa, like what happened this morning? He's like, oh no, it's not this morning. It's been the last couple of days. I've been processing how much time I've lost and how nobody could help me until now. And I get it, right? Not everybody can just go from, oh, I'm so glad I'm better now. There was anger and resentment, and there was a whole bunch of stuff that
Anger, resentment, grief, and it's really normal. So when you get a fibromyalgia patient better, it's like the stages of grief. First, just angry at the people that couldn't help them, told them it was all in their head. Then anger and resentment.
Yeah.
And then when they go through that, then there's grief at what they lost in their life, right?
And you do a great job of talking them through, or telling us how to talk people through, what did you learn and whatever. And we did get him out of that slump very quickly.
Yeah.
And he did have a therapist. He had, like I said, the dream patient, did everything right. And you are going to get those people that all of a sudden reality hits them in the face and they were like, I lost some time here. And I'm like, yeah, but you're still here. And now we know, and now we can, now you have this magic little blue box that you can put in your pocket. But to just talk about using 35 with the emotions as opposed to 970. So do you think that would be indicated even if you don't adopt an acupuncture model?
I'm not sure. I've honestly, literally, Sunday night was the first time since 1994. So first time in 30 years that I've ever done that.
Yeah.
Never did that. And when he was feeling the pulses, if we did 970 and the meridian, it's like the meridian tensed up.
Yeah.
It's like you had to clear the energy flow in the meridians. And this is George. That's the only, George and Harry. George got it from Harry. Thinking about acupuncture meridians as associated with the physical function, the emotional processing, and the movement of energy in the body. It's like George, I had a shoulder injury, had it for 2 years, and spent 1 year getting it treated on the outside, then went to the junior clinic, and Chuck Ponsonby is taking my shoulder apart muscularly with his gnarly fingers. And then passively, they could get it all the way to here. Actively, it went to 45 degrees. And I think that's called horizontal. Yeah. So 45 degrees. And George said, come to my office, end of day. Okay. And there's 6 acupuncture meridians that cross the shoulder. And there's probes on this old microcurrent machine. And he runs 0.3 of a hertz from an acupuncture point down by my wrist and one up on my face or my neck or someplace. And he does 6 seconds on one, 45 degrees, 6 seconds on another, 45 degrees. He puts pericardium 7 and pericardium 1 up on my chest wall, 6 seconds, goes to 90 degrees. What? Goes back, does the other 3, back to 45, goes back to the pericardium, does it for 12 seconds, and the range of motion went to normal, has been normal ever since.
Wow.
And it's like, wait, pericardium meridian is the heart protector, and I was in the middle of getting divorced from the children's father. Oh. And it just, so thinking about and listening to those stories for that many years. And then having Pat Lawless and Sandra Megan and all of the other acupuncturists we've had over the years, and then finding out that FSM, like you have to have your fingers on the pulse because FSM changes the pulses in 5 seconds.
No, I know
But there was this goiter.
like all good stories. There was this goiter. Okay, pause the goiter. Let's get to some of the questions.
Yep.
To goiter. Okay. Dana writes that she has an appointment with an FSM chiropractor tomorrow. Not sure if her custom care is working. She says, I know it's pulsing as one of the protocols is for the eyes, and I can see the lower frequencies flicker. I'm wondering if there's an obvious pair to use as a test. And you have big eyes right now.
Yeah, because
We don't treat the eye.
yeah, number one, why do you have a protocol for your eyes? Who wrote it? Who said you can use it? There's that whole thing. And usually the custom care is fine. Frequencies below 20 or 30, the little bars are sketchy. So you take the alligator clips off, you put the leads in water, and you put, let's say, 94 and 200 on. So make sure the concussion protocol is running 94 and 200, and it's in water. Then look at the little squares. And if the frequency is low or the current is low, the optical scanner can't pick up the signals. The obvious pair to test is 94 and 200 and make sure the current is at 100, 150. All right, then.
Leaf asks, ever had a patient who can't feel the treatment no matter how high you turn it up? Not that you want them to feel it.
Of course. Yeah, it's like they shouldn't feel the current, and not everybody gets dwarfed. And some people that get dwarfed won't admit that they get dwarfed. They get relaxed. That's why we feel for softening. And why do you want them to feel it? And you can say it's like the current is something you shouldn't feel.
Yeah.
And you actually don't want to turn it up past 200 on almost everybody. And it depends on what you're treating. So don't worry about it, Leaf. It's okay. All right. What's smart meters and such? Okay. So Dana says voltage gated ion channels, which smart meters and such disrupt. Okay. I'm having a little trouble with this because is there a paper or anything that says that smart meters disrupt voltage gated ion channels? I've never read anything published. I've never seen any data. I hear a lot of blah, 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 blah. Danger. Here, there's 1,200 cell phone towers within a mile of my house. And a smart meter is going to be a problem. It isn't for me. I have my little ring. I have my hearing aids. I'm not any crazier than I was before. I don't know. Dana, I don't know. But the other thing is, look up and find an actual study where they measure voltage gated ion channels. They measure them, they turn on a smart meter, and the voltage gated ion channels change. And how do your voltage gated ion channels tell the difference between a smart meter and the 1,200 cell phone towers and the TV station that are all within a mile of your house?
Debbie asks, what would you run as maintenance for those coming in every month, even though they feel great? I tell patients to keep coming because prevention is better than cure. She runs concussion and vagus fascia on the anatomy train lines. She runs your lumbar and cervical because she can, but maybe she's running it too much. She also runs 970, 32. She says she means 35, 102, balancing the energy centers. So yeah, my maintenance protocols really all depend on what the pathology was initially. So I think if it's a joint, does the joint need vitality in the cartilage, vitality in the joint surface? I'm testing them when they come in though. So their maintenance treatment, still starts as almost as if they were a new patient. I want a pain scale. I'm doing a sensory test. I'm doing range of motion testing. Something is going to pop up that's going to lead me to what happens. Like, even though people feel fine doesn't mean they present symmetrically. That's, I let the range of motion do the talking. Anya asks, do we have a specific emotional approach in depression and mourning? Mourning as in grief mourning.
Grief mourning, it really depends on the situation. For me, I couldn't touch it. I just not my husband and my son 9 weeks apart. That's just no. So my naturopath gave me medication for it, and I ran concussion in Vegas, emotional relax and balance. That helped, but it's just tincture of time. And we talk about grief in the core. You don't run grief first. Grief is the surface. Underneath it, the first stage in mourning is what? Denial. There's no denying that there's 2 dead bodies there, so I was fine with that. There's anger. Yep. Why didn't he do this? Why did he do that? Blah, blah, blah. There's resentment. And then there's fear. And you just go through the layers, and then you finally get to grief. And then you didn't get in. 35 and 102 is Harry Van Gelder's frequency for balancing the crown center. And on the advanced, it's on the list is copper. And I don't know that it's the same thing. I've used copper before as 35 on somebody that had a problem because of a copper IUD, but 35 and 102 for the energy center, 35 in the heart center, 35 and the solar plexus, 35 in the acupuncture meridians. That's interesting. And I have no idea if copper has anything to do with that.
I use 35 and 102 if someone's really dwarfed and they don't want to be dwarfed when they're leaving. So patients who drive an hour to see me, they want to feel back in their bodies. They don't want to feel stoned and floaty. I found that 35 and 102 can actually help with that as well.
Or 6.8 and 38.
That's the go-to, I know. But
35 and 102 is a good idea.
35 and 102 it's as well. So
Yeah.
Interesting. Copper.
Allie, is there an acupuncture to FSM translation, too much heat? And that's 40. So when there's only one slide, the poor acupuncturists have to live with it for 4.5 days. And the meridian is tinny or too much heat in it. It's 40. You just want to quiet it down.
Interesting.
Ooh, you read Debbie's.
Debbie says, a quote that I always think of when I get stuck: change the way you look at things and the things you look at change. That's from Wayne Dyer. Yes,
I love Wayne Dyer.
Such a great quote. Thanks, Debbie, for that. That can be our quote for today, and we use that too, like with optimism, pessimism, like the obstacle is the way. There's all these Stoic quotes that I fall in love with all the time. But you're right, like you can look at an obstacle as an obstacle, or you can look at it as a challenge. So
you can ignore it and just walk around it. That's my approach. What is my ring made of? This is an aura ring. Yeah. And it just tells me how I'm sleeping and how many steps I made.
I had a daughter's friend who is going to medical school right now, and she's, oh, Kim, I see you also have the ring of despair. And I'm like, the ring of despair? So as a medical student, her aura ring is telling her nothing good. She doesn't sleep enough. She doesn't move enough. She doesn't do anything. So she's like, every day I'm dying. So
yes. My ring, I'm sitting there with the stomach flu last Wednesday, which is a 24-hour bug that I get like once every 12 years. And my ring says, your resilience is great. Okay, glad you think so.
That's so funny. The ring can also be helpful so sometimes I'll wake up and I'm like, hey, I don't want to jump to my data to see how I sleep. I'll say, okay, I slept good or I slept not so great. because I've had the sniffles, I keep thinking, okay, I've had the worst sleep, but I'm actually sleeping quite well. So it can also go the other way where you're like, oh,
Okay.
and then maybe placebo because my ring told me I feel good. And I'm like, you're right, I do have more energy.
And I wake up feeling a certain way, fatigued, fuzzy headed, and I know what that feels like. Then I look at what the ring said, and I got 4% REM sleep last night. Okay, that's what it feels like when you don't get REM.
Yes. So it can be very helpful to put those, you're all about pattern recognition.
Note to self, go to bed earlier.
Yes. So Linda just popped a question and I'm going to answer that super quickly. We talked about this with my TMJ talk. So she's asking about the small device that helps control jaw tension. Now, Mary Ellen Chalmers doesn't like, and I trust everything that she says without hesitation, she doesn't like them in the long term because they can change the occlusion, the bite. The teeth can actually shift because you can't close your mouth at night. So in the short term, it can be helpful. They're called NTIs, which stands for nociceptive trigeminal nerve inhibitors. In the short term, they can be helpful for programming. It worked in my case that I wasn't a grinder, but I was a clencher. And the inhibitor just snaps on your two front teeth so that you can't close your mouth. The minute you start to close, the reflex goes off to relax the nerve. And I had it less than 6 months and I haven't clenched since. And in that short period of time, I didn't have any shifting. So Mary Ellen Chalmers says absolutely not. And they can be very bad used long term. So I'm just going to put that disclaimer out there because she says, yes.
And there's Summer, the client that started having severe head pain as soon as his smart meter went on his house. And I don't even know if I have one, but never had headaches before. And when he left the house, the head pain stopped. He had to move. The other thing is you can tell the power company to take the smart meter off and they charge you an extra $10 a month because somebody has to come manually read the meter. But there is an opt out for the smart meter. Listen to David Musnick and Roger Billica, and the EMF stuff is a real thing. I don't mean to be dismissive about it, but specifically about disrupting voltage gated ion channels. I'm not sure what that's about, but in one of Billica's talks, he talked about a kid that basically became psychotic.
Right.
And they did all this nutritional stuff, none of the meds worked. And then he said, okay, let's start over. When did this start? We rearranged his room and they put his bed in the corner while all the wires came. And they took a Gauss meter in and the magnetic field there was really strong. They moved his bed back by the window where there were no wires. And the psychosis was gone in about 2 to 4 weeks. Right. So I know there are people that it affects, but I'm wondering if there are people that are more sensitive to it than others for some reason.
Yeah. One more question and then we're done.
I know.
Louise says 28-year-old young son has knee pain that improved with acupuncture, although would not sustain. Got an MRI which showed a partial tear of the patella tendon. What is the best series of frequencies for partial tears? Christmas tree in the front, bumblebee in the back. I would have, no. So I'll let you go and then I'll.
Oh, okay. I was going to let you do it because it's, I'd put Christmas tree on top because the patellar tendon is at the end of the quadriceps.
Yeah.
So you want to run at the length of the tendon. I'd go top to bottom rather than front to back. And if you look at the patellar tendon, it's flat. It's thick and flat. And it's 124 and 77, right? Yeah.
I would also add 783 just because of the mechanism, the way that the patellar tendon meshes with the other connective tissue. So anytime you see like the white flat tendons on netters, they usually have the broad attachments, and the broad attachments, just the mechanism of how the patella acts as the lever, the periosteum can get also very irritated with, even though the tear is in the tendon proper, it can still be irritated, the periosteum.
And then for me these days, because I run into it so often and unexpected, so I check for it on everybody. Check the tone in the quadriceps.
Yeah.
what was he doing that was strenuous enough to take? Have you seen what the patellar tendon looks like in a 28-year-old male?
Yeah.
So I'd at least check the tone in the pectineus, the brevis, the quads, the adductors. And if they're tighter than they should be, try 81 and 10. Just check.
Things that happen at the gym. So yeah, I would still check, because like you just said, and the quote that always gets me through on a daily basis is, stop pulling people out of the river and figure out why they fell in the first place. But it's very helpful, because we could treat the tendon for sure, 124/77, and that frequency, we use that on athletes all the time. That helps with delayed onset muscle soreness. It helps with workout recovery. It helps with everything. But if it's partially and only in one leg, there's something that quad, I would say you had check the range of motion and check the tone in the quadriceps. Like, why is that quad so much tighter that it's creating that tear?
And what exactly was he doing with just the one leg? Was he doing a squat with both the legs? And yeah, he should avoid squatting, I would say. Duh. Yeah. What is it? The first rule about bailing out a boat is to stop shooting holes in the bottom of it.
Yeah.
And Louise, the lipoma frequencies are in the advanced, and I don't remember what they are. You just look on the advanced list. It's 77 on A and something else, and then 97 adipose on B, I think. But you have to look it up. I don't keep all of them in my head.
No. Again, fastest hour of the week.
It's so fun.
So fun. This was a good one. Never got to 80% of my list, but that's okay. I'll see you next week.
And I never got to the goiter story.
I'll put that on my notes. Goiter and everything else. We'll just
gonna have to start doing it twice a week.
Okay. Kevin just said we're gonna have to start doing it twice a week.
Oh, Kevin, that's just silly.
I don't know. It sounds good to me. This is what the thing I look forward to.
I know. I can't wait for Wednesdays.
But then I have to come home from the office early, and that never happens.
Yeah, no.
Yeah, no. Sorry.
Once a week. All right, everybody. Thanks for coming. We'll see you all next week.
See you next week. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.